Medurstand Understanding Medicine.
Professor Aziz Rehman from Medurstand-Understanding Medicine. Today we're going to talk about approach to chronic diarrhea. Now, I would be mostly focusing on chronic diarrhea because acute diarrhea has got altogether different etiology and different approach. So I'll be focusing on chronic diarrhea, and it's actually a very vast group of disorder. So I will not be able to go into the fullest details. Some of the condition will be only touched and others will be discussed in some more detail. But this should provide you an overall approach to chronic diarrhea. What is the definition? At least 2 stools, maybe just one per day, but that are abnormal in consistency. Now, both may be important. Frequency of passage of stool, which may be 2 or more times a day, but more important than that is consistency. Now, if the stool is soft or watery, and especially if it is mucoid and has got some blood stain in it, then that is certainly diarrhea. Even if the frequency is once a day, somebody having once a day stool that is watery but is going on for the last 4 weeks or more, that will be defined as chronic diarrhea and will be treated and investigated as such. So there may or may not be associated additional symptoms. If there are, that would give you the clue to the possible diagnosis. So whenever you take history, you would of course ask about the frequency of stool passage and also the consistency over the time, and also any additional symptoms like abdominal pain, like bleeding parectum, like dark color stool, like weight loss, other things like that I'll go through as we run through the presentation. So what defines chronic and what differentiates chronic from acute? I think this is the general concept. Less than 2 weeks is called acute. Typically acute diarrhea is just few days actually, but by definition anything less than 2 weeks would be called acute diarrhea. And then 2 to 4 would be called persistent. It could become chronic, but at this stage it is called persistent. But any diarrhea which is more than 4 weeks would be called chronic. It may be recurrent. If it is coming and going, but it is more than 4 weeks, it would still be called chronic diarrhea and would require certain investigations. So the classification, I think there are several ways you can look at diarrhea, and there are several ways of classifying it. One concept is functional versus organic. That means functional is just a functional gut disorder, usually psychological in origin or due to some medication. But there may be an organic cause. That means there is some physical abnormality in the form of inflammation or infection or malignancy or malabsorption or some other problem. So I think this is extremely important because functional diarrheas are just nuisance and they are usually treated symptomatically after reassurance, whereas organic diarrhea may indicate a serious underlying condition. So I think first skill you need to develop is to be able to differentiate functional from organic diarrhea. Then watery versus mucoid. Watery means lot of water, and mucoid, mucus is actually produced in the large gut. So presence of lot of mucus would indicate that the pathology is in the large gut. So I think that will also help. Watery diarrhea may be secretory diarrheas or absorptive diarrheas, and usually acute, but chronic diarrheas may also be watery, sometimes due to some tumor which secrete certain fluids. Then secretory versus absorptive, right? The large gut has the main function of absorbing fluid. So that is what makes the stool its typical consistency. But if water is absorbed not in lesser quantity, the stool will remain watery or at least semi-solid. Or there could be secretory diarrheas. In many conditions, a lot of fluids are secreted into the gut, and it could be small gut or it could be large gut. So you can actually differentiate between secretory and absorptive diarrhea. This is more important from pathophysiological point of view. Then diarrhea versus steatorrhea. Diarrhea is, of course, what we know is the passage of a relatively soft or watery stool, but steatorrhea is passage of fat. Steatorrhea is passage of fat, and this is typically a symptom of some malabsorption, some small gut disease, some pancreatic disease, some other diseases which we'll discuss later. So presence of fat, and that fat could be visible, not only just a fat, it would change the looks of the stool, it would change the consistency of the stool, it will change the smell of the stool, and it will also change the floating character of the stool. It will become very sticky. So if these features are present, we call it steatorrhea. So then we primarily focus on some primary malabsorption rather than diarrhea, because the symptoms may be similar and patient may just describe it as diarrhea, but when you go to the detail, then you will find out this is actually steatorrhea. Just to remind that many malabsorptive disorders may not cause full-fledged steatorrhea. Small gut versus large gut diarrhea, and this is another concept. And then finally, we come to the etiology. Etiology is very, very wide. So just let's briefly go through it. Functional diarrheas, like for example, we're talking about chronic diarrheas. I'm just going to remind you again, we're talking about the chronic diarrheas. So it could be functional diarrheas, and the most important is IBS. You know, IBS is a chronic disorder which is characterized by abdominal pain, frequent defecation with changed consistency of the stool. So this is the IBS, and there is some relief after defecation. And this is the criteria, Rome 4 criteria. But there are some other gut disorders which do not fulfill the definition of IBS, but they are also functional. So I think functional diarrheas, if it is, when would you think that this is functional diarrhea? When patient has got chronic diarrhea with nothing to suggest a physical cause, no bleeding per rectum, no tenesmus, no fever, no weight loss, and patient has some psychological symptoms also. I think that is how we suspect functional diarrheas, but you don't want to miss a physical cause. So unless you are sure, you must do further tests. So drug-induced diarrheas, there are many drugs which can cause chronic diarrhea. Purgative abuse, the people, especially elderly people who are very, very obsessed about their gut movement, and they take a lot of purgative and they pass soft stool and then they complain of diarrhea. So I think that possibility has to be ruled out. Some other drugs, metformin for example, I've seen people who are taking metformin and they're complaining of chronic diarrheas, and when you go through the history, then you figure out that this is actually the drug. I think in my experience, nothing is more rewarding than finding a drug causing patient symptoms and just taking him off that drug and patient becomes better. So I think you must spend some time to find out if there is any drug which is causing diarrhea in the particular patient. Chronic infections. Now, normally we feel that if patient comes to a tertiary care hospital, a specialized hospital, then these conditions are ruled out, because most general practitioners, they would give treatment for amoebiasis, giardiasis and helminthiasis. But that is an assumption. So my practice is, if patient comes from a rural area and there is no definite history of this treatment, so I normally treat them for amoebiasis, giardiasis, helminthiasis, because this is a short 3 to 5 days treatment, and this will avoid lengthy, cumbersome, expensive workup. So I think in my practice, I treat the patient with these, unless there is clear-cut possibility of another disease or patient has taken many courses of these drugs. So I think otherwise I would give that trial of this. Tuberculosis is still common. Tuberculosis can affect small gut and can cause diarrhea and can cause constipation. HIV, very, very important. I think this is my message to you. In our society, we still underestimate the prevalence of HIV. If somebody comes with truly chronic diarrhea, which is refractory to medication, must consider HIV infection. In HIV, there is actually possibility of superadded infection, many atypical organisms, many parasites which do not cause infection in a normal healthy person with intact immunity, but they cause infection in these patients. So I think you must keep a high index of suspicion about HIV. Malabsorption celiac disease is like a gluten enteropathy, fairly common. It may start in the childhood or it may start later in life also. And there are all grades of diseases. Don't expect that patient would have frank diarrhea. The patients who just have little bit of soft stool and bloating. So I think keep a high index of suspicion. Tropical sprue is actually an infection, giardiasis. Giardiasis can affect small gut, and so it can cause actually a malabsorption like syndrome. And small gut syndrome, anybody who has undergone some gut surgery and there is a gut loop formation or the gut is small, there is a possibility of bacterial overgrowth, and that may also cause diarrhea. So IBD, I think very, very important. After functional diarrhea, in real life, after functional diarrhea is ruled out, we actually consider IBD, inflammatory bowel disease. I have 3 separate lectures on inflammatory bowel disease, introductory lecture and a lecture on ulcerative colitis and a lecture on Crohn's disease. If you're interested, you can watch those videos. But we will take IBD as just one condition here. So if somebody has history of chronic diarrhea and there is bleeding per rectum, there is mucus pass in the stool, there is pain in the rectum, and I think in this weight loss, abdominal tenderness, you must consider IBD. In some cases, there may be extra intestinal manifestations also that may also give you a very good clue to the diagnosis of IBD. So diverticulosis, especially when there is superadded infection, diverticulitis, that could cause diarrhea. And there are actually many other colonic diseases, ischemic colitis, other types of colitis. So I think chemotherapy-induced colitis, they can all, radiation-induced colitis, so they can all cause chronic diarrheas. Then malignancies. So this is something we really worried always, and this would be particularly a possibility in elderly people. Now, in younger people, middle-aged people, there are still possibilities of malignancy, though less common. And let me remind you, there are some benign tumors also. There are some tumors which are benign, which can produce a lot of secretion and can cause diarrhea. So I think you need to consider malignancies as well as benign tumors in patients with chronic diarrhea. So this may not be the complete list, but this I just came up with the common condition. IBD and IBS are most important in the common at least. Now, what point you would like to elicit when you take history? Of course, the frequency of motion and nighttime diarrhea. Now, if somebody has to wake up at night to pass stool, generally speaking, it indicates a physical cause, right? It is possible that patient with the IBS might also wake up at night and pass stool, but most people who have to wake up at night, especially multiple times to pass stool, they are almost certainly cases of some physical cause, some infection or some inflammation, and not just IBS, because IBS diarrhea is typically in the daytime. In fact, the first half of the day is the worst. Then foul smelling stools. Stools, of course, are normally also little foul in smelling, but the smell has become very, very foul. That would indicate bacterial overgrowth. So it may indicate a malabsorption or it may indicate some infection. Fatty and frothy stool. The stools are normally brown in color. But of course, the color varies from time to time depending upon what we eat. But if the stools are very fatty, yellowish in color and frothy, and they float on water, they should suggest the possibility of steatorrhea along with this foul smell. In obstructive jaundice also there may be clay colored stool. A review of medication. In history, you must go through the medication patient is taking. also the alternate medicine, also the non-prescription medicine. Okay, so I think that is very important. And then piles. Piles, in my opinion, do not cause diarrhea, but there is importance of pile in the history taking. Why? Because if somebody has diarrhea, and we are very particular about bleeding per rectum. If there is bleeding per rectum along with diarrhea, and so if the stool is blood stained, and immediately we assume a possibility of a serious infection or IBD or something serious. We typically rule out IBS if there is bleeding per rectum. But there is a possibility that somebody actually has IBS, but the bleeding is because of piles. So that is why I think every patient with chronic diarrhea must be asked about piles. If there are piles, hemorrhoids, and then you must ask if the diarrhea is separate than blood. In that case, the blood will be passed after the stool and in the form of droplets, and the stool itself would be not blood stained. So I think that will give you the clue. Then passage of worms, of course, simple things that would also give you history, an important clue to the diagnosis. So this is history. Of course, you would ask about the history of weight loss and overall feeling of fever and any other condition, nausea, vomiting, traveling. They're all important, but these are the most important points. Then out of all these points, there are certain points in history which we call red flag symptoms. Now, if there are red flag symptoms, we immediately get alerted because that indicates something potentially serious. That indicates that we must do further workup. That indicates that we must find out the cause. For example, weight loss. Now, a little bit of weight loss may be possible in functional diarrheas also, because like in IBS, it is the food which precipitates the pain. So patient may avoid taking food. So there may be a little bit of weight loss, but if weight loss is significant, then you must suspect something really serious. Malignancy or HIV infection, tuberculosis or IBD. And then bleeding per rectum, particularly if the stools are mixed with blood. If this blood is present in the stool, then it indicates colonic inflammation, most probably inflammatory bowel disease or diverticulitis or some malignancy. So bleeding per rectum, I have already made a point that bleeding per rectum from hemorrhoids is possible with with IBS also. Fever, of course, there could be fever due to another cause, but fever associated with diarrhea would indicate some inflammation, either infection or inflammatory bowel disease. Tenesmus. Tenesmus is a feeling of incomplete evacuation or feeling of fullness or feeling of pain or discomfort in the rectum after you have passed stool. In a normal person, after passing stool, one feels very relieved and light, but if you feel that the stool is still present in the rectum and there is some discomfort, that means that there is tenesmus, and that would indicate some inflammatory or infective etiology. Obstructive symptoms. Now, if patient feels that the stool gets stuck, then of course there is a possibility of a tumor, benign or malignant or stricture. So after taking history, then you proceed with physical examination. Of course, you will do general physical examination. You will look at the patient and see if there is any pallor or if there is any other condition or other problem. But of course, overall build is very important. If patient describes he has lost weight, that is part of history. But on examination, you can have reasonable judgment that the patient has lost significant amount of weight. Patient has lost weight, so that will give you a diagnosis, a clue to the diagnosis. Then pallor, that means patient is anemic. That would mean either chronic blood loss or malabsorption. So I think that is important. Then abdominal masses, extremely important. When you examine abdomen, if you feel masses in the abdomen, and these masses could be intestinal masses, particularly in the right iliac fossa. An intestinal mass in the right iliac fossa could mean either tuberculosis in our country or Crohn's disease with regional lymphadenitis or things like that. So other abdominal masses may also be important. And hepatosplenomegaly. Presence of splenomegaly and hepatomegaly is very important. They would indicate a physical cause. Then digital rectal examination. I think in all patients with diarrhea, you should do digital rectal examination. This is my approach, and you might find hemorrhoids, you might find perianal disease. In 50% patient with Crohn's disease, there may be perianal disease in the form of fistulae or other problem. And then many tumors, the many cancers are within the reach of finger. So I think digital rectal examination must be performed in all patients who present with chronic diarrhea. Now, investigation, it would vary from person to person, but I'm just going to give you an overall outline. Of course, we start with CBC, complete blood counts. You can expect some drop in HB. There may be hypochromic microcytic picture indicating iron deficiency, or there may be macrocytic picture indicating folic acid or vitamin B12 deficiency. All are possible in chronic diarrheas. Liver function tests, liver tests may be abnormal in IBD or in tuberculosis, HIV. Particularly, you will be interested in albumin. There are conditions called protein losing enteropathies, or there may be hypoalbuminemia in malabsorption. So albumin particularly and PTI will be really interested. Renal function test, again, some kidney diseases may be responsible. Thyroid function test. Now this I would do in those patients who have palpitation, goiter, diarrhea but no bleeding per rectum, and there is weight loss. So I think you can easily identify a case of hyperthyroidism presented with diarrhea. I've seen few cases, and it is really a treat to find out that somebody who presented with diarrhea actually had a thyroid disease, and it's so easy to treat. And other tests as appropriate. Stool complete examination must be done, and stool for ova and parasites and fat cells. Fat can be sometimes measured in grams to see if there is fat malabsorption. Undigested muscle fibers are also indicative of malabsorption. Stool may be examined for some special tests that I'll just go through later. Now, stool for Clostridium difficile toxin. Clostridium difficile is a very problematic infection. This occurs luckily not very commonly, mostly in its hospital acquired infection. People who work in the hospital or people who were admitted in the hospital for some reason, they might develop Clostridium difficile infection, very refractory to treat, and this has got typical fruity smell. The patient will describe the stool has got fruity smell, and you can confirm the diagnosis by measuring Clostridium difficile toxin. This should be done in appropriate patients. Then stool for calprotectin. Very important test. Calprotectin is actually a protein which is secreted by the neutrophils. And if colon is infiltrated with neutrophils, then it is likely that the stool will be positive for calprotectin. Now, of course, in all infection, bacterial infection, shigellosis, salmonellosis, other bacterial infection, cholera, stool will be positive for calprotectin, but we do not do this test in that situation. So I think this test has got value if you're dealing with chronic diarrhea and there is tie between IBS, which is very common, irritable bowel syndrome, and IBD, inflammatory bowel disease. So in my practice, if somebody has chronic diarrhea and you want to differentiate between IBS and IBD, I think you can do the test called calprotectin, stool for calprotectin. If it is positive, it would imply infiltration of large gut with neutrophils, and that would mean that you need to go for colonoscopy. It is not IBS. Very important test. Then stool for H. pylori antigen. H. pylori is known to produce upper GI symptom, intractable ulcer, but it can cause lower GI symptom also. So H. pylori antigen can be tested from the stool. So then if you suspect gluten enteropathy or celiac sprue, I think the screening test is IgA total and IgA TTG. TTG is tissue transglutaminase. Actually, we are interested in tissue transglutaminase, which is an actually antibody. It could be IgA type, IgG type, but IgA has got more correlation with celiac disease. But patient with celiac disease may be actually deficient in IgA. So if IgA is deficient, some other people also may be deficient in IgA. If somebody is deficient in IgA, then IgA TTG would be negative even if the person has got celiac sprue. So that is why we do IgA. So if IgA is absent, then we will go for IgG TTG as a screening test. Confirmatory test may be endoscopy, upper GI endoscopy, but the screening test is this IgA TTG. Now let me tell you, this disease is not rare. So you need to raise your suspicion. Anybody presenting with chronic diarrhea, you must suspect celiac sprue or gluten enteropathy. Carbon breath test is done, it's not available here, but it is done to rule out lactose intolerance or other carbohydrate intolerance diseases. In anti-HIV, very important, somebody coming with chronic diarrhea, with fever, weight loss, and anti-HIV must be done as a screening test. Now this was the basic blood test and the stool test. Now we can do some imaging tests. In imaging, there's a limited role actually. Abdominal ultrasound is very important because an expert can pick up intestinal masses. So if there is tuberculosis of the intestine, and that can be very easily picked up by ultrasound. If there is Crohn's disease, terminal ileum thickness, stricture formation, fistulas, and regional abscesses, regional lymphadenopathy, thickening of momentum, all can be picked up on ultrasound. So if there is another abdominal pathology, that can also be, I think, at least you will get some clue on the ultrasound. So ultrasound, very simple, non-invasive test. All patients with chronic diarrhea should have ultrasound. It would also tell you if there is any hepatosplenomegaly also. So abdominal CT scan, very good test, because the limitation of ultrasound is that it does not penetrate gas in the intestine, so it may miss some diseases. So abdominal CT should be done. If ultrasound has not given you the detailed information, abdominal CT scan, which could be plain without contrast, but more importantly with oral contrast. If you suspect upper GI disorder, or you could do an enema, the contrast CT scan, enema CT scan, very useful. And then barium meal studies. Barium meal is like you were given barium and immediately this X is taken. That is primarily done in acid peptide disease and the duodenal disease, but barium follow through is done for malabsorption. And it would be even better if you do the double contrast study. A nasojejunal tube is passed, and then contrast is injected to the jejunum, and then you take small gut series. That will give you much better detail. Similarly, the barium enema can be done for large gut disorder. This could also be done with double contrast. Air mixed with contrast is injected through the rectum. This is more time consuming. It requires more human resource, but gives you much better picture. It is actually called, this CT, this can be done on conventional X-ray or can be done on CT. This is called colonography, virtual colonography or virtual colonoscopy. So it is as if you see the colon. So very useful test. Endoscopy is very important. These are usually done at the end. Why? Because patient usually does not want to undergo these investigations. They are slightly unpleasant. They may not be available everywhere, and so we do these tests as a final confirmatory test. So we could have proctosigmoidocolonoscopy. Proctoscopy means that just seeing the rectum, and then the sigmoid and the colonoscopy. I think best is to do a colonoscopy, fiber optic colonoscopy, so that the entire colon is visualized. Patient would require at least 48 hours preparation. You have to clean the gut and then you see the colon, but it is extremely useful because you literally see what's inside, and you also have the chance of taking a biopsy. In case of IBD, you would take biopsies. In case of malignancy, you would take biopsy, and if the colon looks normal, even then you take biopsy just to document that everything was normal. And endoscopy may be also very reassuring. In patient with IBS, doing a colonoscopy may be useful just to demonstrate that there's nothing physical. That may be very reassuring for the patient. Enteroscopy is examination of small gut, and this could be done with special enteroscopes, or it can also be done with capsule enteroscope. Capsule enteroscopes, these are small gadgets which can be ingested. They have actually built-in camera and battery. They acquire images and then they transmit to a computer which is worn by the patient, and then images are analyzed. So these are all investigations which are done in specialized center, but colonoscopy, which is most relevant, is available, I think, in most tertiary care hospitals. That should be sufficient in majority, but if you need these investigations, of course, then you will have to refer the case to specialized gastroenterology units. After discussing etiology and the symptom, the sign and laboratory tests, let's come to the treatment. Treatment approach varies from person to person. Since there is diverse etiology, so the treatment has to be tailored according to the individual patient. But I am just giving you an outline the way I take these patients. So first of all, unless patient has got already taken this course, I would give them a short 3 days course to treat common infection in our country, amoebiasis, giardiasis, and the worms. So I think that should be given, and then we, according to the situation, we go. If patient has got symptoms compatible with IBS, I have a separate video, and in this video also I earlier mentioned how do we suspect IBS. If the symptoms are compatible with IBS, then you just give a trial rather than going for further test, right? So, and then of course, based on a response you review. If patient does not respond well to trial, then you have to review. You have to consider some alternate diagnosis, because you just gave trial on the basis of assumption. Then if somebody has got marked weight loss or significant weight loss, and there is also fever, intermittent or continuous, and especially if on examination you find that the tongue is coated, there is candidiasis on tongue, I think there is extremely strong suspicion of HIV infection, and you must do anti-HIV as a screening test. And of course, if that is positive, then you go for confirmatory test. Although anti-HIV is also literally confirmatory, but you would also go for further test, and then you give heart treatment as appropriate. And then if patient has got predominantly bloating and there is no gastrointestinal blood loss, no GI bleeding, there's bloating but no GI bleeding, then I would suspect some malabsorption, and I would rule out gluten enteropathy by doing IgA and IgA-TTG. And then of course, as a trial, I would ask the patient to have abstain from wheat for a couple of weeks and months, and then I would reassess the patient. If symptoms have completely gone, then the diagnosis is confirmed, and patient may be asked to stay away from gluten containing diet, and patient, the further tests, endoscopy is actually optional, but of course can be done if you are not 100% sure. Then if the stools are acidic, that would indicate carbohydrate intolerance, which can occur in acute infections also, but in chronic setting it would indicate lactose intolerance, and you would try lactose abstinence. You will ask the patient to avoid lactose for a couple of weeks and then see how the patient responds. Now let me give you one very important information. Even other diarrheas, I've seen even other diarrheas, when we stop wheat or lactose, patients do improve. Most patients, they would show some improvement. But in order to say that patient has got lactose intolerance or gluten enteropathy, there has to be significant, very significant, undoubted improvement. Only then you can say the test is positive. Then if there is blood in the stool, you have already ruled out hemorrhoids, and if the blood is present in the stool, and then of course you need to do colonoscopy. There is no way you can avoid colonoscopy. If colonoscopy is not available, then you should do maybe barium enema, double contrast to have some idea, but colonoscopy is best. And you may find IBD, inflammatory bowel disease, then you give the appropriate treatment by we start with mesalamine, but then of course we move on with further treatment. They are covered in separate diseases. In fact, I have made a video on ulcerative colitis, and there is detailed discussion about mesalamine. If you find something else, then of course accordingly you can treat the patient. So it's a process of evaluation and reviewing and then changing your stance. So I think ultimately you should be able to find the right diagnosis and the right treatment if you are methodical and if you are consistent. You have to keep patient in confidence. When you're doing tests one by one, patient might get the impression that you're absolutely lost. You don't know what to do next. So you must discuss the plan with the patient. You must discuss with the patient that first we'll have simple tests, and then if needed we'll do more sophisticated tests, and at the end we do the invasive or colonoscopies, because patient understands your plan and doesn't stop following up. So this is all about chronic diarrheas. Let me present the summary. Chronic diarrhea is a common condition with vast spectrum, and irritable bowel syndrome and inflammatory bowel diseases are relatively common. Investigate and treat as appropriate. You may start with one hypothesis, then you assess the response, then you may change your stance, and that is how you treat these patients. Refer to the gastroenterologist when indicated. Don't lose time, don't waste time. So if you think there's something that you cannot do, please refer to the concerned specialist for further investigation and further treatment. With that, I'd like to thank you for watching my video. I'm really grateful, and then I'm looking forward to see you in my next video. Thank you. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine.